Hi there, my name is Dr. Benjamin Olson. I am a second year internal medicine resident with Bay Care North Bay Hospital. I'm presenting to you today a very interesting case entitled Chest Pain to Septic Pneumopericardium, a gastropericardial fistula from perforated marginal ulcer after Roux-en-Y gastric bypass. A little bit of background, marginal ulcers are a recognized complication of Roux-en-Y gastric bypass. Sometimes they can even perforate and very rarely fistulize into adjacent structures. Some of the mechanisms, of course, including acid exposure to surrounding tissues, any sort of foreign bodies left like staples or sutures, and also there's always risk factors with these things like tobacco use, NSAID use, diabetes, and H. pylori infection. In particular, gastropericardial fistula is a very, very rare, often fatal condition with a communication between the GI tract and the pericardial space, and it's really only associated with malignancy, peptic ulcer disease, some GI surgeries, including Roux-en-Y gastric bypass. And the issue with this is that the clinical presentation is usually pretty nonspecific and looks a lot like acute coronary syndrome, pericarditis, or even sepsis. So diagnosis a lot of times is delayed because of these things. So a little bit of background, 56-year-old lady comes in. She's got a history of Roux-en-Y gastric bypass about 3 years earlier. Was complicated by marginal ulcer disease, and patient continued using tobacco. She also had hypertension, type 2 diabetes, COPD, and some psychiatric diagnoses, which we'll talk about in a bit, as well as chronic opioid use. So she came in with 2 or 3 days of intermittent chest heaviness, radiated to her left arm and her shoulder. Initially, she got evaluated. Sinus tach is what we found with negative troponins, and we had a non-ischemic EKG. We did a chest CT, and it did show a little trace pericardial effusion and some irregular thickening of the proximal stomach, so she was discharged and recommended to follow up with endoscopy with a GI doctor. She then re-presented 37 days later to the ED with similar symptoms, had a full cardiac evaluation again. She even had perfusion imaging, and that was normal. She was discharged again. She then returned 24 hours later, same symptoms, and then they did an echocardiogram, and this demonstrated progression to large pericardial effusion. CT of the chest then showed a large pericardial effusion with pneumopericardium, which we see here on the bottom left. Very suspicious for gas-forming infection. Also, it was noted that the proximal gastric pouch was in close proximity to the pericardium, so we had some concern about some sort of communication between the two, especially thinking about the fact that it's pneumopericardium. Patient became septic, was transferred for emergent surgical management. She had a pericardial window, and that did show purulent fluid, enteric contamination, and this confirmed septic pericarditis. Also, on the diaphragmatic surface of the pericardium, there was evidence of a fistula with green succus that was freely flowing into the pericardium. Concurrent exploratory laparotomy then showed perforated GJ anastomosis with erosion into the pericardium. And given that there was extensive inflammation, basically definitive repair was deferred so that we could send them to a tertiary center and have definitive treatment. Her postoperative course was pretty prolonged, complicated, lots of infections, septic pericarditis, peritonitis, hypoxic respiratory failure. She was ventilated at one point, and ultimately she was able to be discharged in stable condition with additional antimicrobial therapy. So basically, this case shows a significant delay in the diagnosis of a patient who has some known risk factors with Roux-en-Y gastric bypass, marginal ulcer disease, and just kind of nonspecific chest pain. We did see early CT evidence of irregular thickening in the stomach, close communication basically between the pericardium and the stomach in and of itself. And basically, these should have started to make us look at communications or associations with a fistula or some sort of communication. Additionally, we did want to note that the patient had multiple psychiatric diagnoses, and it's impossible to determine if that actually influenced the diagnostic course, but it's something that we need to kind of be more aware of.
We want to keep in mind to avoid any anchoring biases moving forward.